Assalamu alaikum and good evening to you all. Welcome you all to our weekly oncology club sessions of gynecological malignancy. Today is our tumor board sessions, and our renowned faculties today are Professor Dr. Amita Maheshwari. She needs no more introduction. And another is Dr. Raju Chako. Sir is the Professor of Medical Oncology, CMC Vellore, and Sir started the Medical Oncology Department in CMC in 2000. And he is the principal investigator in several clinical trials and other research. And another is Dr. A.K. Goodman. She is the professor in Harvard Medical School, Massachusetts General Hospital, Massachusetts. And Dr. Bhagyalakshmi Nayak, she is also our good friend. She is the chairman of the Foxy Oncology Committee. And today our presenter are the Dr. Farhana Ishrat Jahan and Dr. Shushmita Sarkar, and another is Dr. Ruksana. And all three are the resident of National Institute of Gynae Oncology and National Institute of Cancer Research and Hospital. At first, I request our president of the session to give us permission to start the session. Sir, please.
Bismillahirrahmanirrahim. My heartiest welcome to all of you, particularly our faculties from abroad and participants. We are for continuing this type of study. You all know it's a very long time for gynae oncology. We have fixed the date of one Tuesday evening. Today we have got Tumour Board, and as Sana already has said, we have three speakers where they were present with cases, and a social listen from our faculties. Our cases. So without any delay, I think we should start now. It's already 7 minutes past. Please start now. Sana.
Thank you, sir. Thank you. First, I request Dr. Farhana Ishrat Jahan to present your case.
We have polls today.
Yes, sir. We have polls. Shorna,
Yes, ma'am.
please show the poll questions.
Yes, ma'am.
All the participants are requested to answer the poll questions.
It's just a sports organized oncology club. Everybody can take part in this.
I have a slide. What is slide? এটা চলে যাচ্ছে
Poly is over. We should start now.
Farhana, please go to.
Am I audible, madam?
Yes, you are.
Is my
Yes, you are.
slide visible?
Yes.
Respected faculty from home and abroad, my teachers, senior colleague, Assalamu alaikum. This is Dr. Farhana Ishrat Jahan, President, Gynecological Oncology Department of National Research Cancer Research Hospital, going to present today's test presentation. Mrs. X, 35 years, woman, normotensive, non-diabetic, presented with gradual distension of lower abdomen for 3 months. CT scan of whole abdomen shows large cystic mass with internal soft tissue component and septation. Mass has extended up to the right lumbar region. Peritoneal fat stenting is seen around the upper part of the mass. Ascites fluid present with peritoneal involvement, suggestive of malignant right adnexal tumor. There is no CT plate available to us. I am informing only report. The tumor marker CU125 more than 1000 unit per ml, but CEA and CA199 within normal limit. Now question is, can we go for primary cytoreductive surgery?
So are you asking us, or will you describe the criteria? How do we select cases for primary surgery?
Yes, madam. I am asking a question. Can we go for primary cytoreductive surgery?
Okay, so what we need to know, examination findings, which you did not present. So what are the factors which decide whether we should do primary surgery or neoadjuvant chemotherapy? Largely, you can divide them into 3 categories. One is disease-related factors. Second will be patient-related. And third is infrastructure. Okay, so disease-related factors, if you see in this patient, she has ascites, she has peritoneal disease, and she has an adnexal mass. But all these per se are not contraindication for going in for primary surgery. Okay, so what are the factors which may disease related? If there is stage 4 disease, had there been liver mets or lung mets or pleural effusion or extensive lymph node enlargement, right from mediastinal to supraclav, inguinal, if there is extensive, just presence of few nodes again is not a contraindication. If there is extensive peritoneal carcinomatosis kind of picture, which is difficult at times on CT scan, so that can be missed on CT scan. If there is disease at porta hepatis, or if there is extensive bowel mesenteric involvement, if there is large diaphragmatic deposits. So these are some of disease-related factors where primary surgery may not be advised because reduction. And to be little more sure, you can do a diagnostic laparoscopy to know the involvement. If there is a borderline case where you are not sure whether to do primary surgery or give chemotherapy, a diagnostic laparoscopy is useful. But if there is clear-cut case where you think optimal cytoreduction is not feasible, then you give neoadjuvant chemotherapy after confirming the diagnosis of ovarian malignancy, either by biopsy, or if you are using ascitic fluid only, then I think cell blocks are important so that you are sure you are not dealing with some other malignancy. The second component is patient-related factors. So in your, I didn't get patient-related, but what we need to see performance status of the patient. If it is 2 or above, PS2 or above, may not be a suitable candidate. If there is hypoalbuminemia, so albumin is very important. Age of the patient, elderly patients more than 65. And other factors are like comorbidities. Your patient doesn't have, so comorbidities, especially cardiac comorbidity, or if patient has recent history of thromboembolism, if there is history of myocardial infarction, acute recent history. So all this will, make patient high risk for aggressive, extensive surgery. And in this case situation also, you may prefer giving neoadjuvant chemotherapy. The third is infrastructure related. So you need to see one, patient, whether patient will be able to afford in case you need post-operative higher antibiotics or nutrition parenteral. And you also need to see infrastructure in terms of peri-operative care. It's just not surgeon, but it also involves anesthetist, intensivist, dietitian. So all these also are important when deciding between primary surgery and interval debulking surgery. So that's my answer to your question. I don't know if AK there, she wants to add something. Or Bhagya?
Bhagya, should be some late. AK, are you here?
I'm here, and I thought that was brilliant. I completely agree. I would say that in general, the data is pretty compelling, that a few rounds of neoadjuvant chemotherapy followed by a good cytoreductive surgery is equivalent in terms of survival and recurrence rates to primary upfront surgery. So the reasons to consider primary cytoreductive surgery may be based on your assessment that you can do full, complete cytoreductive surgery, and that requires having good imaging studies, or as you said, you're evaluating intraoperatively and making a decision to abandon if you cannot do complete cytoreduction. All right, so either based on your CT scan, which shows diffuse carcinomatosis, liver metastases, whatever it shows that would be a contraindication. Thank you. The preoperative imaging here in and of itself doesn't suggest to me that you cannot do primary surgery. And the other reason to consider primary surgery is for alleviation of symptoms such as bowel obstruction, severe pain from a large tumor, and so forth. So yeah, no, I thought it was a very lovely presentation. Thank you.
How will we prepare the patient for surgery?
Sorry, what is the question?
My next question is, how will we prepare the patient for surgery?
Okay. So you want to know pre-operative preparation.
Yes,
Is that the thing? So your patient is fit, you have decided to go ahead with surgery, and you want to know what kind of preparation we give.
I want to go for primary cytoreductive surgery.
AK, could you please answer? I didn't get the question well.
Sure. So when I think about preparing a patient for surgery, I see that as following in several different components. So component one is, are they medically fit, right? What is their nutritional status? Are they anemic? Do they need to have a blood transfusion? Those sorts of things. Also, what is their ASA risk factor, right? Do they have severe cardiac disease? Are there issues that need to be evaluated? Do they have diabetes that is out of control? What's their hemoglobin A1C? How well is their diabetes controlled? Those things will impact wound healing and so forth. So that's one aspect of preparing someone for surgery, is to do a full medical assessment and to be sure they do not have cardiac risks or other risks that would cause them to potentially die or have a post-operative death or have a poor outcome such as a wound infection, a pulmonary embolus, and so forth. So that's one component. The second is you've decided, nope, this person's fine, we're going to take them to the surgery. What's your preparation? There's a few things to consider, and we have been calling that here ERAS, which is Enhanced Recovery After Surgery. So we have a whole ERAS protocol which we use that includes you doing a antibacterial soap wash of the abdomen for at least 3 days preoperatively. That's the first thing. The second piece of it is to consider bowel preparation with laxatives and antibiotics, so neomycin, erythromycin, and a good bowel cleanse. And the final very important issue in preparation, which we've identified, is being sure they're not dehydrated. And so nowadays we actually allow patients to drink electrolyte solutions up to 2 hours prior to surgery, right? No solid food for 8 hours prior to surgery, but electrolyte solutions up to 2 hours. And in fact, the patients do much better than if they're fasting completely, which includes fluids, for the previous more traditional approach. Then in terms of other preparative things to consider is protection against Mli and thrombosis, right? Because this group of patients has potentially a huge burden of clot, right? Especially this large pelvic mass. She may have a clot underneath that when you lift that up, she could have a pulmonary embolus, and you need to consider giving her some sort of a blood thinner. We use unfractionated heparin. That's our standard one that we use. And we use pneumatic compression air boots. So those are my things.
The patient, she underwent laparotomy. The perioperative findings was size of right ovary 20 centimeter into 15 centimeter, and left ovary was 15 centimeter into 12 centimeter. Both are partly cystic, partly solid. Multiple deposits are present in undersurface of diaphragm, rectum, and peritoneal cavity. Surgical staging was 3C. Primary debulking surgery was done, which includes total abdominal hysterectomy, bilateral salpingoperectomy, total omentectomy, bilateral pelvic lymph node dissection, and removal of multiple malignant deposits from peritoneal cavity. Histopathological report shows papillary serous cyst adenocarcinoma, high grade. Cervix, both-sided pelvic lymph node biopsy, omentum, tissue from peritoneal cavity shows metastatic serous carcinoma. According to her attending physician, she received 6-cycle adjuvant chemotherapy with paclitaxel and cisplatin from April 2019 to July 2019. 4 weeks after chemotherapy, CT scan was done. No detectable secondary deposit. CO125 within normal limit, but she was lost for 1 year due to COVID-19 pandemic. After 1 year, she consulted with her attending physician and he advised for CT scan, and CT scan shows recurrent mass of pelvic cavity involving hysterectomy stump and matted with pelvic, small bowel lobes, serosal surfaces of anterior wall of the rectum, base and superior surface of urinary bladder, marked ascites with extensive peritoneal deposit and multiple metastatic soft tissue mass at omental and mesenteric fat planes, abdominal and pelvic lymphadenopathy, right-sided mild pleural effusion with anterior mediastinal lymphadenopathy, multiple simple cysts in liver. So my question is this a case of platinum sensitive?
Agya has joined. Raju Chaku, sir.
So, yeah, by definition, this is a relapse which is more than 6 months, and therefore would be considered platinum sensitive.
Yeah, but Dr. Raju, I think I have a little reservation because we don't know the status of the patient for the last 1 year. So
True.
it's a very thin line to tell whether she is platinum sensitive or not, because by the time she has come, she already has very advanced disease.
No, I completely agree, and that's the difficulty in this particular case. But practically speaking, this is platinum sensitive by all definitions otherwise. So
Yeah, I agree with Dr. Chaco, because we have a follow-up at 4 months. Of course, we don't have later
6
follow-up.
months.
And at 4 months, she was all right. So
4 months.
her CA125 was 24 and there was no disease. So she is platinum sensitive. One more thing I think we have to stress here, she's young lady, some 36 or 39. So important to know her family history. Is any family history of breast, ovarian, or any other malignancy, and to consider a genetic testing. So was family history elicited? Is there any significant family history?
No significant family history. She has no significant family history of breast ovarian carcinoma.
Still
Okay.
looking at her young age, I think if it is available, it's always better to do the BRCA testing at least.
She was follow-up after only 4 weeks, not after 4 months.
Oh, that was 4 weeks. Okay.
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 The next question is, what will be the next chemotherapy regimen?
So yeah, the way that I would decide it is, I mean, once I've decided to treat her with a platinum, then I could repeat the same platinum paclitaxel, provided she had a good, you know, uh, uh, history of doing well with the regimen itself. You know, she shouldn't have had too much, neuropathy with the paclitaxel. If otherwise, I would continue with the carboplatin and paclitaxel in this particular patient. She's young, provided her kidney functions and other things are normal. So I would give her carboplatin and paclitaxel again, and see how she does over the next 2 or 3 cycles of chemotherapy.
Anybody has second opinion or agree with sir?
Yes,
I
I
think
think I would also consider this patient as platinum sensitive, although we don't really truly have. And platinum with, I mean, if there wasn't much toxicity with taxane, or otherwise who have options of gemcitabine or or PLD, so one of those, but definitely a doublet platinum-based chemotherapy. The question, I don't know if you want to discuss whether we will consider giving anti-angiogenic therapy
Yes,
point in this.
that is the thing actually. Yes.
Ascites and effusion and extensive disease, a young lady. So, Dr. Chakko, what is your opinion? Would you consider BEV?
So, practically speaking, I think many people would opt to give this patient bevacizumab. However, I must say that my own experience with the drug is very limited because of the costs involved in giving this drug here. 15 milligram per kg every 3 weeks is quite a lot of bevacizumab, and we'll have to make sure that this patient has otherwise no comorbidities that would make her ineligible for bevacizumab. Otherwise, yes, she's a candidate for bevacizumab.
My next question
But
is,
one must understand that, bevacizumab, in terms of prolonging overall survival, there's limited information. Okay, there's a lot of phase 2 data which suggests that, but phase 3 data, convincing phase 3 data to suggest that it improves survival is lacking at the moment.
Right. So, may I ask you, Dr. Chakku, would you use 7.5 or 10 or 15? Although you mentioned 15 milligram, but
see, 15 is what has been used, in the
but
trials. But you could use 7.5 and 10 and all that. But again, it's a matter of using it in our patients. The cost is what is prohibitive.
Right, I agree. Although now at least we have generic, so it's.
Yeah, I mean, we still use it. It's not that we don't use it, but it's just that it's.
Yeah, I agree.
Really
Chakku, I want to add one thing, that as you mentioned that there was a gap of 1 year. So we know with this, what Amita was telling, with all the issues like ascites and extensive disease, there is always
Well, I think you need to come closer to mic, not audible.
So sorry, I was telling that at this stage, there is some data in favor of using bevacizumab, but whether will you challenge only with paclicarbo and see the response, and if not going to respond, then we will add bevacizumab, or you will use the bevacizumab because it is a recurrence and there is ascites and all these things. Let us forget about the cost.
Yeah, if the cost is not an issue, bevacizumab would certainly be a consideration here, provided there are no other comorbidities. I'd be careful about the bowel, for example. Look carefully to see whether there's bowel involvement, because that using bevacizumab with bowel infiltration means that there's a likelihood of perforations. I'd watch out for hypertension. Those sort of things, would be my considerations.
So can I tell it like that, Dr. Chacko, that there are some tempting data about bevacizumab, but few things we need to consider, that it is not a magic drug. It knows very strong data of giving OS benefit, and it is not without any cost, not only the money. There are so many issues that we need to think about. Sometimes we forget that you said very rightly that if there is a extensive bowel involvement and all these things, we may do some harm by giving bevacizumab in this type of patients sometimes. And it may also delay, so that is the thing, that it is not, somebody may think that it is a very tempting drug that we should just add, and the only excuse we find is the cost. But as you were trying to mention, that it is not always only the cost. Cost is a big issue, but there is no great data that it can make a big difference. Say if it is 1 year after, only paclicarbo or liposomal doxycycline carboplatin may give a good response, and we can get a good sustainability.
Yeah, yes and no. I guess, some people will swear by giving bevacizumab in this setting. I'm a little more, conservative in using bevacizumab, but that may be just a personal bias, and mainly because, the type of patients I see don't exactly afford it.
Right. I think same here, Dr. Chacko. We also, keep it in reserve more like platinum refractory, as rather, giving it and
Yeah, although the data suggests that bevacizumab would be more useful in the platinum sensitive rather than in the platinum resistant groups. If you look at the data, it looks
but there is no
better in those groups. But yeah, I completely agree with you that.
So Amita, why I always try to discuss like this, that in our region, when we are not fortunate enough sometimes to miss this type of drugs or treatment, we need to really understand how much we are losing, because the studies and the data, there is some benefit, there is some advantages, but sometimes maybe, just like Dr. Chacko, I am not also a very big fan of jumping in with bevacizumab at the very starting, unless I become helpless. But I feel, it is my take, that maybe we are not losing much in most of the cases, because it is not a big addition, like huge survival benefit or a huge thing. So if we compare our scenario, cost and availability, everything, well, if we can use it, it's fine. If we cannot, probably we are not missing a great thing. That is the point that, like Dr. Chacko, I want to say it's a biased comment from my end.
No, I totally agree. And I think what is also very important for our patients, we need to tell them the realistic benefit of the thing. I have seen many times they will sell their property, everything, in the hope that this is some expensive, miraculous drug. So we also need to tell that the benefit would get from expensive therapy. So I absolutely agree with you, Dr. Kamal and Dr. Chacko, and that's what our practice is at Tata Memorial.
Yeah, Amita, for you in an institute like Tata, it is very, you have the strength of giving this message. Say in our setup, sometimes it is challenging, because another big fallacy in our region is people think expensive is good. So when they think there is an option and the drug is expensive, sometimes they don't realize it is a palliative treatment and giving few months benefit maybe, but they are always, sometimes it is a pressure from their end that they want to use. As you said, at the cost of their selling their last piece of land. So there we need to really give the real explanation whether they should go for it or not. That is very, very important in that discussion. Corna, please mute the other person. Okay, Shana, we can move, I think.
Yeah, and
Yes.
Dr. Kamal, I have one thing for
Yes,
curiosity. Yeah,
Yes.
for Dr. Chacko. Is there any role of a single drug carboplatin in CA ovary? What are the indications from your side? What are the indications?
So, I would, in this young patient, I would try and use a doublet. However, if there is a patient whose, whose performance status is not so good, a little older person, for example, I might just decide to use single agent carboplatin in this patient, in this group of people.
So, Dr.
And in an upfront setting, are the indications also the same that her performance status is not good, that you'll decide on a single agent carboplatin?
Yeah, so there are several patients whom we have just given like neoadjuvant single agent carboplatin and taken them up for, cytoreductive surgery after a couple of cycles when they become better from their disease. One of the good things about ovarian cancer is because it's platinum sensitive, just a few cycles of chemotherapy and you'll see a totally different patient in front of you from, somebody who's had really bad ECOG status to somebody who's, reasonably fit for surgery at that stage.
Right. I think, Bhagya, we also if patient is very sick, we at times even give weekly AUC2. And when they are a little better after 1 or 2 cycles, then we move to combination chemotherapy. So that also can be done. But if you're talking about scientific evidence, icon 3, I don't think anyone, practice by choice giving single
exactly.
agent.
I wanted that only, because there are evidence that which shows that there are some centers which do practice, but it has never been, no one, though we brand it as platinum sensitive, but we always add the paclitaxel along with that. So whether the paclitaxel works or the carboplatin or the platinum agent works, that's again a dilemma always. Okay, so let's go ahead.
My second and last question is there any role of secondary cytoreductive surgery?
In your patient, I would say no. There is no role in this patient doing secondary cytoreductive surgery. But if you want to know who are the patients suitable for secondary cytoreductive surgery, these will be platinum sensitive who have, if you follow desktop 3 criteria, then you need to check patient's performance status 0, previous surgery, which has to be upfront surgery, not neoadjuvant IDS. If first surgery was upfront and there was no gross residual disease at first surgery, and to support the use. Not a patient who has multiple has ascites. She's not, I don't think she would benefit from secondary cytoreductive surgery.
Yeah, what is Dr. AK's opinion?
I agree with Dr. Amita. But one thing I would add in terms of secondary cytoreductive surgery is to just think about it this way. Can you completely remove the disease? If you cannot, then surgery actually does not give you a survival benefit. And I think, in fact, from the desktop 3 and other studies, in fact, your survival is less. So you're actually not doing your patient a favor, and you potentially are harming them. So your consideration of surgery is really only in the setting usually of isolated disease that you can completely resect, or if you're pushed to do the surgery because of a crisis, such as a bowel obstruction, that you can manage surgically, right? Not all bowel obstructions can be managed surgically, especially if they're multifocal. But if you have an isolated bowel obstruction, that can be fixed with a simple bowel resection and reanastomosis or a colostomy. Those would be other indications. So yes, as you were saying, I think in general, you are considering chemotherapy. And sadly, unfortunately, if we just want to take a step back and look at the big picture, these patients are not cured, right? So this poor young woman who's recurred a year or so later, while there are most definitely other interventions that will improve her survival and give her some more time, she will ultimately die from her cancer. And you need to keep that in mind as you're thinking about what you're going to offer her, and you're thinking about the toxicities and the morbidity, and also the what we call a financial toxicity, right, which is very huge in Bangladesh, where people are paying out of pocket potentially for some of this treatment. Is it at all going to be helpful for them? Yeah.
Okay, next motion.
So AK, what's the take on HIPEC in practice in your at your center? HIPEC, are you practicing it or?
We're really only using it with mucinous tumors, and we do it in collaboration with our surgical oncology colleagues. And these are for advanced mucinous pseudomyxoma tumors and such. I know with the New England Journal of Medicine article about it in other ovarian cancer that potentially it has a role, but that really hasn't gained any traction in Boston. Yeah.
Right. I agree. So I think the message what we are trying to give here is that secondary cytoreductive surgery has very, very limited role in highly selected patient. And as AK mentioned, there may be detriment. In fact, GOG213, the gynec oncology group trial showed that secondary cytoreductive surgery may be detrimental. So one has to be very careful and select patients very carefully, not to offer it to every patient at recurrence.
So Amita, I want to add with you that some of our oncology colleagues believe that when there is some recurrence, like, you know, I mean, the very common term of so-called debulking is there. And there is a belief that if some surgeon colleagues can do some debulking, then the giving the chemotherapy may do some good, which is not true. And it has been proved by many trials. And I think that is what you and AK wanted to say. So not only for the surgeon, also for oncology colleagues, that this type of so-called debulking in this type of recurrent setup is not going to help. Whatever we need to do on the first surgery, where we need to do the best surgery to get a good outcome.
Yes, sometimes for oncology colleague, they insisted us for the doing the surgery. There is the little response or recurrence. If please do debulking surgery, and then we'll go for the next chemotherapy. Yes.
Amita.
I said it's a very unfortunate situation, recurrent ovarian cancer. So basically both surgeons and medical oncologists are not comfortable. So we want to send to another specialty. A surgeon will say chemotherapy, and a medical oncologist will send to surgeon for surgery. So that's the thing.
So patient keeps on moving from here to there actually.
Yes.
Right.
So again, I have a little doubt. What about this if using gemcitabine instead of paclitaxel? Dr. Chaco, can you please light about what is the indication of repeating pacli with carboplatin and or changing to gemcitabine and cisplatin?
So, you know, I generally would go with paclitaxel if the patient has had a good response. No, but, you know, see, in this patient, where you've already primarily debulked the patient, I have nothing to go by to see, you know, how the patient has done with my chemotherapy. I only know that I failed because the patient relapsed, or, you know, I see that the disease has come back after 1 year. But now let us take a situation where, for example, I had given platinum and paclitaxel as neoadjuvant therapy, you know, and if I had seen a fantastic response to the paclitaxel and carboplatin, that would have been my choice if this patient came back with platinum sensitive disease, you know, later on. Now, if the patient, for example, doesn't want to lose her hair, if the patient, has a lot of peripheral neuropathy, let us say the patient is a bad diabetic, and I don't want to give that steroid that I would normally give with paclitaxel to these patients. These are all the kind of situations where I would choose a second drug other than gemcitabine, other than paclitaxel, in combination with the platinum drug. So there's a lot of choice that we have now. Gemcitabine, we have PLD, pegylated liposomal doxorubicin, which is a possibility. So all these are drugs that we can use instead of paclitaxel when we, for whatever reason, we don't want to use the paclitaxel.
Dr. Chacko, I have one question to you that you raised a very technical issue that after such a surgery, when we have given 6-cycle chemo, we cannot really claim that this 1 year interval was, there was a big significant, contribution from the chemo or not. So for example, you have very rightly said that if it is neoadjuvant, we can really see the response and we can say that, well, it has done well. After more than 6 months, we challenge with the same drug. But say upfront surgery is done and we have given pacli-carbo as a gold standard. But what is the standard interval we will consider that you will believe that along with surgery, the chemo has also worked, so you want to re-challenge it? Because here
not really. We can only go by what we call, platinum sensitive or platinum resistant. So if the relapse is, less than 6 months, I will say definitely don't give a platinum drug there.
Sir, then her attending.
That's the only answer I can give. Sorry, I'm sorry. Yeah, please go ahead.
Then her attending physician advised her second-line chemotherapy. So she received 8-cycle chemotherapy with gemcitabine and cisplatin from June 2020 to November 2020. After second-line chemotherapy and CT scan report, finally she was referred to National Institute of Cancer Research Hospital for further management. On examination, per-abdominal examination, per-vaginal examination, there is nothing abnormality detected. Only vault is thick on rectovaginal examination, and the tumor marker CA125 260 unit per ml. Ultrasonogram of whole abdomen shows no metastatic lesion. CT scan of whole abdomen, no residual disease. Suspected treated metastatic soft tissue around right perihepatic region below right lateral abdominal wall. So PET scan was advised. PET scan shows no metabolic evidence of local recurrence. Metastatic right hilar lymph node. PET scan shows metastatic right hilar lymph node. Decision of Tumour Board was FNAC from mediastinal lymph node, but radiologist comment was FNAC not possible. So my question, how can we proceed with the patient?
Okay, so
please go ahead.
Oh, I was going to say there is this American expression, which is to sit on your hands and stop, just leave this patient be and see what happens, because she's asymptomatic. Potentially she has some small volume of disease that will at some point make her ill, but you have recently given her a tremendous amount of therapy, and she needs to live her life. She's going to recur in a way that she will be sick, and until that moment, give her a break. That would be my recommendation. Sometimes psychologically, this is very difficult for patients. They have a lot of anxiety. And then I pull out my tamoxifen card, which is to say, let's give you an anti-estrogen, and put them on a little tamoxifen. And there is some very, very old data to suggest that that's not a bad thing to do, and potentially it might slow things down. And it definitely has a little bit of a placebo moment, but that might be another alternative. There is a small risk of blood clots with it that you need to keep in mind. Sir. Dr. Raju, you were going to say.
I completely agree, and I was going to say exactly the same as you did. Okay, except my thing is, I wouldn't have done that PET scan at all. I would have been just so happy that she had such a good response with the chemotherapy and the patient was well. Why chase, something that you're not going to be able to cure anyway? All right. So now is the time to, give her a good quality of life, let her get on with her life. And, when she gets into trouble, she will come back. You must remember that this kind of recurrent ovarian cancer, with every succeeding course of chemotherapy, you'll get a shorter and shorter response. So, my thing is, you're eventually not going to change the overall survival, but you can, treat a patient with 20 courses of chemotherapy in that time, and you might just do the same, give her a good quality of life by just waiting and watching and treating her when she becomes symptomatic and gets into trouble.
Okay, is it tamoxifen or letrozole you will be suggesting?
Oh, either one's fine.
Either.
I think tamoxifen potentially in a younger woman has less side effects in terms of arthralgias and so forth, but either one's fine. Yeah.
Okay.
Do you want to know the ERPR status of the tumor before giving tamoxifen or letrozole?
Sure, absolutely.
So yes, but tamoxifen also has some sort of anti-angiogenic action, I guess, apart from anti-estrogenic. So that's the reason we also give tamoxifen to occasional patients with this kind of situation. So I think for the sake of discussion, we may discuss the role of genetic testing and PARP inhibitors. I do understand huge cost and practically very few patients can afford, but just to complete the discussion.
Yeah, some people would give PARP inhibitors in this kind of a patient as maintenance therapy, even without any BRCA or HRD test.
Yeah, I mean,
And they'll say, you've had such a good response with the platinum, so that's a test good enough to give them PARP inhibitors. But like you said, with the very high cost, we'd be very, very reluctant to suggest that to a patient.
Dr. Chacko, if it is a BRCA positive, say for example, as Amita was telling for discussion's sake, if it is this lady is BRCA positive with this age, and we had this second time there is a response and very small residue, only medicinal note, will you be giving for 2 years of RP there?
Yeah, for whatever it's worth, yes.
Okay.
Thank you for all practical purpose. Now we know that PET scan was not indicated, whatever it is. But since we already have done and we see a single node in the mediastinum, so is there any role of a single field, small field radiation to this node? Just for curiosity.
Yes.
Dr.
Yes.
Yes.
There is some paper, they are telling that if you have a single node metastasis, you can do SBRT and sometimes it is giving good result. So there are, it is not, but it is more in favor of, the pariotic type of nodes. I have not seen a paper of medicinal, but I have seen papers that if it is single node recurrence of pariotic in the abdomen and there is no other thing in the PET, they are suggesting you can do a SBRT to the node and it is giving good response for certain time.
Yeah, theoretically, yes, but this particular patient with extensive intraperitoneal disease at relapse and this asymptomatic lymph node lying in the chest, I think I would say I wouldn't consider radiation. Also, and it has its toxicity giving to radiation to mediastinum.
Amita, I was not telling about this. I was telling that if it is not for mediastinum, I have no data, but for pariotic single node, if there is no other thing,
in fact,
that
yes.
Yes,
I absolutely agree, and we have a couple of patients who have beautiful response to radiation, pariotic nodal recurrence. So we have treated patients, but
The
not.
other
Not for pedestal.
other
Yes.
thing that you must keep in mind is that remember that the PET CT positivity doesn't always mean that there's tumor there. In our, subcontinent, one must consider the possibility of pulmonary tuberculosis and, such other. So we shouldn't, as oncologists, we shouldn't close our minds and think that everything that's PET positive is metastatic disease.
Right. In fact, I was also about to mention, especially isolated chest node could be just an inflammatory or infective or old COX, because we don't have baseline PET to compare with. So we won't even consider this as a positive node.
Thank you for patient hearing.
Shona, Dr. Vijay Ahuja, he is the President Association of Gynae Oncologists of India, has joined. You please make him co-host.
Okay, ma'am.
Shona, please.
Hello, good evening. I don't know whether I'm audible.
Good evening, sir. So our first case has been completed. Next, I request Dr. Shushmita Sarkar to present your case. Shushmita. Today is our holiday, so participants is less today.
So
So
Shahana
what
is
is
not
the
happy with
occasion
100.
today? What's the
All right.
Shahana is not happy, Amita, with 100 participation.
Yeah, I think so. What's the occasion? Any occasion for holiday?
This is a religious festival day today. We say Shabe Barat. That's why just
Okay.
2 weeks before Ramadan, we have a religious day. That's why today is a holiday.
Shushmita, please. Shushmita, are you here?
Yes, ma'am.
So please share the screen and start presentation, Shushmita.
Respected chairperson, respected foreign faculties, my teachers, and my senior and juniors, good evening. I'm Dr. Shushmita Sarkar, resident of National Institute of Cancer Research and Hospital, going to present my case. She is a 12 years girl who underwent laparotomy followed by left-sided salpingoforectomy on February 2020 without surgical staging. Histopathology report showed it was yolk sac tumor. Then she received 6 cycles adjuvant chemotherapy with BEP with bleomycin in first 3 cycles up to 21st August 2020. So my question is to Sir Raju sir, what complications may happen if 6 cycles chemotherapy with BEP is given? Hello?
Dr. Omita or Dr. Bhagwanath?
I'm sorry, I was muted. Yeah. So I was asking, when you say 6 cycles of chemotherapy with BEP, you saying how much bleomycin was given?
Bleomycin was 3 cycle, first 3 cycle.
Okay. So she's just received under this thing. Otherwise, one of the problems that you have with a young person receiving that is pulmonary toxicity and fibrosis that may set in. Other than that, the BEP is quite a difficult regimen to actually get in. And, one can get a lot of cytopenias and you may need to, rescue them from a febrile neutropenia during these cycles. And that's what generally is the problem. And then, of course, there's the whole issue of infertility and all in this patient, which one must keep in mind.
Sir, I have another question.
Please go ahead.
Sir, why 3 or 4 cycle chemotherapy BEP is given in germ cell tumor? Why not more than 4 cycle?
That's enough.
Why it is limited to 3 or 4 cycle?
We don't need to give more than 4 cycles. So, if it is a very sensitive tumor like a dysgerminoma per se, even 3 cycles is enough. And if it is, a non-deschominoma, people tend to give 4 cycles. And there's usually what is seen that it's not required to give more than that.
Can I add just one thing?
Yes, sir.
See, normally these tumors are associated with elevated tumor markers. So these tumor markers are guide for your chemotherapy. So if your tumor markers fall very early, I mean, you have to give 2 to 3 cycles after normalization. So you can tailor the duration of chemotherapy based on tumor markers. They will tell you the effectiveness as well as help you in guiding the duration. One more for the medical oncologist, Professor Chaco. Whether once we reach the normalization after 1 cycle, can we switch over to, omit the bleomycin, just give it opposite and platinum? That is achieving a complete biochemical response as a consolidation.
Yeah. So see, if that depends on whether we are talking about this therapy
The yolk
as
sac tumor.
adjuvant therapy, or whether we are talking about it as, in the setting of advanced disease.
No, adjuvant. I'm talking only
Yeah.
of adjuvant.
So in the
when you have a
adjuvant
yolk sac tumor.
setting, at the
Yeah.
time where you've already debulked the tumor to almost 0, usually you expect your tumor markers to come down to normal, if not, to 0, depending on what we're looking at. So in this particular patient, I would just give 4 cycles and, at the 10 weekly doses of bleomycin like is normally given, and that should be sufficient. You don't need to give more anyway.
Okay. So Dr. Ahuja, we have some experience in dysgerminoma giving only EP, not giving mycin in adjuvant setting. But I think, there is a trial which showed, I'm not sure if it's in testicular tumor or ovarian germ cell tumor, which showed that 4 cycles of EP are inferior to 3 EP in non-dysgerminoma.
Yeah, no, I agree with that. My question was, after we achieve a biochemical response, we switch over, reduce the bleomycin after that. Supposing if you give 2 cycles and then just to reduce the toxicity of bleomycin. I'm not at outset.
So, in any case, one won't increase your bleomycin to beyond 300 milligrams.
Right.
Or 300 international units, sorry. So that's the kind of limit, unless you have a patient who's already developing pulmonary toxicities with the first few doses. So one would tend to try and give that bleomycin, especially in a dysgerminoma-like setup.
Dr. Chaco, I think the question that was brought up here is that more is not always good. So in any setup, if we are going for BEP, or maximum 4 should be the issue, because then the dose of bleomycin is the issue. And another thing is that if we are not getting a good response, even after 3 or 4 cycle, then probably we will be moving to another protocol rather than chasing with the same protocol. And in response to Dr. Vijay Ahuja, that there, as Amita was telling, that if we have a plan that the patient is candidate of 3 cycle of BEP, unless there is any visible toxicity, there is probably no data of just dropping bleomycin once after 1 cycle we had a good response. Then we need to continue. But if it is more than 3 cycles, then we can continue without bleomycin, not to drop before that, if I'm not wrong, Dr. Chaco.
Right, and I think there is evidence it's inferior in non-dysgerminoma.
Yeah, primary setting, I understand.
So the main thing was that sometimes somebody of us thinks that more is good. So 3, 4, 5, 6, this is sometimes detrimental. Because
but
it is not giving benefit.
This patient, someone has omitted bleo after 3 and continued with EP. Was it because there was an response, optimum response? What was the reason for continuing EP, an additional 3 EP?
Amita, I don't know about this patient, but there is a culture in our area that some of us believe that any chemotherapy is of 6 cycle. So
Yes.
thank God that it was not all with bleomycin
Yes.
that saved the patient. I mean, sometimes we forget. And another dangerous thing is that sometimes we are not assessing the response. So that is another part where 6 cycle is okay, but it is not okay to give 6 cycle without assessing after 3 cycle. So the common belief of 6 cycles sometimes land up with this type of issue, but I'm not sure about this case what happened.
Okay.
So after 2 months of her chemotherapy, her alpha fetoprotein was rising. That was 523. So what would be her next treatment?
So,
Professor Raju.
so again, no, at this time I would definitely image the patient to see what's going on. Where is there a single place where there's tumor that is producing the alpha fetoprotein, or is it more like disseminated disease? That is the first thing that I would do. And then I would, this is obviously tumor that's coming back very fast, and may require or will almost certainly require more treatment now, because this patient has already had 6 cycles of BEP. Depending on how much disease burden there is at this particular time, I would then decide how to take this further. So if there's a possibility of some local treatment to one area or so of disease, that would be certainly something that I could do. And then I would follow it up with a second line therapy.
Right. And not in this case, but otherwise, I think we also need to keep the possibility of pregnancy happening in between, which can give rise to high CA1, high alpha fetoprotein and HCG. So, also important to rule out if you don't find any disease, pregnancy could be reason for increase in tumor markers.
In her area, she received 3 cycles chemotherapy with paclitaxel up to 15th November 2020. So again, her alpha fetoprotein level was rising. On November, it was 473. On 31st January 2021, it was 973. Then the child was referred to my hospital with abdominal pain and increasing tumor markers. Her bowel and bladder health was normal. She attained her menarche at age of 10. Her menstrual cycle was irregular during chemotherapy cycle. On examination, she was mildly anemic, no palpable accessible lymph nodes. Other vital signs are within normal limit. Parabdominally, there was mild ascites and no palpable mass, but abdomen was tender. Parectally, uterus was bulky for her age. Regarding investigations, serum alpha fetoprotein on 5th February 2021, it was again raised. It was 1383, and other germ cell tumor markers are within normal limit. CT scan of whole abdomen done, which revealed there was a complex mass about 5 into 4 centimeter on the left side. So our diagnosis was Yorkshire tumor. So my question is, what would be her management plan? Over to you, Amita ma'am.
So one thing is, the chemotherapy given at a second line paclitaxel alone was absolutely inappropriate. That's not the drug of choice and not the regimen of choice that Dr. Chacko can say. But I think considering that first surgery was details were not available and there is limited disease now. Maybe I would consider surgery at this point and then more chemotherapy. And I think BEIP, or what will be your chemotherapy protocol of choice, Dr. Chacko?
Smita, paclitaxel or paclitaxel, ifosfamide, and Sushmita, only paclitaxel?
Second line, only paclitaxel was, I feel, inappropriate in this case.
Yeah, I too agree. I mean, I'm surprised that that we treated her only with paclitaxel. That would be a very poor regimen in this particular patient. See, remember that germ cell tumors we are trying to cure, okay? So we we will try to throw as much as possible at her. Short of killing her, we should try and kill all the tumor there. And that's very important. So, that's why I'm saying, at the time that we saw the alpha fetoprotein rising, we should have imaged her to see, where the disease is. And at that stage, we should have gone and, done, if there was just one area of disease, like as was seen in the CT scan now, I would have gone in and immediately tried to take that out and then put whatever chemotherapies that I can at her. That would have been the best possible course of management. Under these circumstances, now I would say I would agree with Amita. I would go in for a surgical management followed by the by
What type of
chemotherapy,
surgery,
and
sir?
combination of TIP or VIP or whatever is as appropriate.
What type of surgery?
So I forgot where the initial mask was, on the right side or left side, same side, or is it on the
Same side, ma'am.
same side? So we can still consider conservative surgery if during surgery other adnexa and uterus are normal. We can leave those structures. It will be adenexectomy and omentectomy, and of course we need to take a proper consent, including removal of opposite adnexa if diseased. But if normal, I think we would still leave the other ovary and uterus in situ.
Professor Dr. Nirja Bhattacharya ma'am is with us. Can we? Dr. Nirja Bhattacharya. Are you here?
Hello, everybody. Yes, nice to be here today. I agree with Dr. Amita.
Yeah, hi, Dr. Nirja.
Hi. Nice to see everyone.
So, Amita, what I can tell that from the discussion, the message that we carry from here is that even these are very chemo-responsive tumor, but we should be doing the assessment properly before starting the chemotherapy, then about the surgery, and also talk with the surgeon about the extent of surgery. And even when we have given 3 cycles of chemotherapy, this type of patient, and we are getting that the tumor marker is rising, then we should definitely go for imaging that Dr. Chakko was repeatedly telling, rather than chasing the patient with so many chemotherapy. Because the secret is, if we don't do a proper surgery or if we keep behind something, best chemotherapy in this type of chemosensitive tumor is not going to melt it down, and we will be struggling with putting her on many and many chemotherapy without solving the issue.
Right, and I'm not sure if in this case the first surgery was an adenexectomy or just cystectomy type, only removing the mass and leaving behind.
Left side is salpingo-furectomy.
Adenexectomy, yeah.
So, Amita, to be very honest with you, we had experiences that what we see in writing, that is not the reality, and sometimes it doesn't match with the imaging. So we sometimes struggle of this type of thing. What do you say, that whether it was a cystectomy or adenexectomy, salpingo-furectomy, that is another question, and it is sometimes to be rechecked because we are not very sure about all these things. But the main thing is that as the surgery is done, we have 2 options: to talk with the primary surgeon and to believe our imaging.
Yeah, and
we need to do it repeatedly.
Read a histopath report carefully, gross part especially.
Yeah,
if there is
that
no
will give
mention
the clue.
of tube, and if it says salpingo-furectomy, that tube was not removed. So
basically, if it is a cystectomy, then the surgery should be done first at the first setting to remove the affected ovary. But regarding salvage surgery after 2 failed chemotherapies in germ cell tumors, at least my experience has not been very good. These patients generally don't do well if they have failed 2 chemotherapies and any surgical intervention. They generally recur very fast.
But Dr. Ahuja, in this case, you won't really call single agent paclitaxel as another line of chemotherapy.
Yeah.
And we are not sure about the dose of BP, what was the dose enrichment, whether it was followed.
Yeah, that's right. But the only problem is the tumor has been fed on chemotherapy and it has been allowed to grow and grow. So you definitely have a tumor genetics which has changed now.
Right.
So yeah, we don't know actually. Yeah, you're right. It's not ideal chemotherapy, but still it's a chemo exposed tumor.
So, in general, I will say that, a tumor that is growing, having received all this chemotherapy, so whatever tumor mass is there is likely to be quite refractory to anyway the treatment that she's already received. So, at least at those doses. So we have to, consider, that this is refractory disease, and to get her out of this sort of situation, we've got to throw just about everything at her, reduce the tumor mass to the maximum. And this may be a patient who needs very high dose chemotherapy and even a stem cell rescue to get her, cured of this disease. Remember that germ cell tumors are curable, and we need to, think on those lines. Of course, the other factors will come into play, but one must keep that in mind when we treat these patients.
So the question comes in whether we are going to delay the chemo, because ultimately you're going to depend on salvage chemotherapy here now. Then doing a surgery which may or may not help, you're delaying the chemotherapy. That's one way of looking at it. Because a residual tumor in epithelial and residual tumor in germ cell is different. So if since you need not get a R0 in a germ cell, as long as you have some effective chemotherapy. And if you don't have an effective chemotherapy, then R0 doesn't help in germ cell.
True. Yeah, you're absolutely right. Yeah.
Yeah, situation we have seen, although she received 6 cycles, but our experience is many times, especially in periphery, they give suboptimal doses because oncologists don't want to manage toxicity. So she received some 6 courses, but not sure about the adequacy of doses and whether drugs were given appropriately or not.
That can be considered. My experience is only with optimal chemotherapy.
Yeah, so
for the sake of everybody, see, a germ cell tumor is one situation where we wouldn't even postpone the next dose of chemotherapy just because blood counts are low. We'll go on with it, provided we aren't producing febrile neutropenia, etc. We would go on with the chemotherapy even if the counts haven't reached the optimal level that we will see in most other chemotherapies in other disease. So it is with that kind of tumor, that kind of treatment intensity that we treat these germ cell tumors. But refractory disease is very common, and yolk sac tumors are famous for them. Okay, so we talk a lot about our treatments, but we must also remember the biology of the tumor. And yolk sac tumor that's coming back after BEP, and that to six cycles, is certainly bad refractory disease.
Yes.
Then she underwent laparotomy on 6th February 2021 in my hospital. Operative findings were there was small hemorrhagic peritoneal fluid. Omentum was adherent with anterior abdominal wall and posterior surface of the uterus. Large gut was also adherent with the lower part of the uterus. Uterus was bulky and cervix expanded and broadened.
Next slide.
Left ovary and fallopian tube was absent due to previous operation. Right ovary and fallopian tube was grossly healthy. Systematic exploration of the abdominal cavity was done, and there was no metastatic deposit. Retroperitoneal lymph nodes were not enlarged. Omentectomy was done. Again, she reported severe abdominal pain 5 weeks after her surgery with moderate ascites, and alpha fetoprotein was again raised, that is 1576. She was then, CT scan was not possible to do, ultrasound was done, and there was moderate amount of ascitic fluid and a pelvic mass. Then she underwent laparotomy on 18th March 2021. Operative findings were moderate amount of ascites was present An ugly-looking metastatic deposit, 3 to 4 centimeter in the posterior surface of the cervix was present. Total abdominal hysterectomy and right-sided salpingoforectomy was done. And that is the specimen showing the metastatic deposit on the posterior surface of the cervix. So my question is, was this operation justified for this young girl?
I would say hysterectomy was. I'm not sure about whether we could have opposite adnexa, right adnexa, if that was not. Hysterectomy was now, inevitable because there was a deposit involving the cervix.
So histopathology report revealed cut surface of the uterine cavity shows a friable growth measuring about 6 into 3 cm extending from the fundus of the cervix, and outer surface of the cervix showed metastatic deposit of malignant tumor composed of serous dual body. So what would be her adjuvant treatment?
Now this is no longer like adjuvant chemotherapy. We are now, trying to salvage her with whatever we can do. So I would, try some, VIP or something at her and see what happens. That's ifosfamide, platinum, and vinblastine.
So what about her hormonal support?
Yeah, I mean, we
I don't know.
can give hormonal support. There's no contraindication giving hormones, but I would maybe let her complete her adjuvant treatment and see how she does, and then we can put her on hormones. So we can supplement hormones.
So ma'am, when should it be started?
So, I mean, theoretically speaking, you can start immediately after surgery. There is no problem. But practically, I think I would let her complete her adjuvant treatment and then start. But you can start right away after surgery. Bhagya or Dr. Girja, any comment on when to start hormone support? Bhagya?
Can I add then?
Yeah.
See, I would wait. See, basically, you need an immediate hormone therapy whenever there is a sudden castration, that the symptoms are severe and you need to institute hormonal therapy in a young woman earlier. But in a woman who has received so much of chemotherapy, the ovarian function would be subdued and she is already on a low ovarian function. So she won't have a drastic menopausal symptoms setting in. So some hormonal therapy would have some, we don't know about the side effects, some thrombotic effect or something which may delay chemotherapy. So here, saving life is more important rather than, hormonal therapy at this point. So I would complete the treatment and then start her on a hormone therapy if she disease free.
Yeah, I mean, that's what I also would do, let her complete her treatment. But theoretically speaking, there is no contraindication starting hormones immediately. And she's just 12-year-old, right? 12 or 13 now.
So we don't need it right now.
So she had total hysterectomy with bilateral salpingoforectomy. How would she be followed up?
I mean, we have to follow her up for her disease, I guess, right?
But before the follow-up, there is a bad, sad news for this young lady, little lady. She was on VIP on her second cycle. Yesterday, she lost. She died yesterday during her chemotherapy.
Oh, toxicity, chemotoxicity?
It may be because she was getting the chemotherapy in hospital. We tried to communicate with her parents, and they told that she died yesterday.
But just to complete it, what did she get between the two surgeries, one in February and one in March?
Sir?
She had two salvage surgeries, for one. There saw one date of February something and one of March. So what are those two dates?
Smita.
None.
Maybe I missed out something.
So I
Date
can
of the
hear
fourth
you.
surgery. Date of the last two surgery.
There was one something in February 21 and was something in March.
Yes, sir.
February and March. Yes.
First week of February, then March. Yes, sir. We have another case. Right? Complete, Sushmita.
Yes. Thanks for hearing. Thanks.
Yeah. We have another case. Please, I request everybody to stay with us. There is another case. This case was discussed in this tumor board in November 2020. We want to discuss it today. And I request Dr. Ruxana to present your case. Ruxana, please.
जी मैडम. My slides is visible, madam?
Yes.
Good evening, Honorable Chairperson, respected home and foreign faculties of Oncology Club and learned audience. Assalamu alaikum. I am Dr. Ruxana Parveen, Gynecology Oncology Subspecialty student of National Institute of Cancer Research and Hospital. I am going to present my case. A 25 years lady, mother of one child, underwent dilatation and curettage due to incomplete abortion in September 2019. Her histopathology report was atypical tropoplastic cell suggestive of tropoplastic neoplasm. After evacuation, her beta ECG was more than 15,000 international unit per ml, and repeat beta ECG was 90,000 international unit per ml after 3 days. Chest X-ray was normal. Rescoring was not done, and she was treated with 3-cycle methotrexate from 8th October 2019 to 6th November 2019. After third cycle of chemotherapy, the beta ECG was 13,000 milli-international unit per ml, and she was treated with Imaco and received 10 cycle up to 25th April 2020. During Imaco therapy, the beta ECG level gradually decreased at a level of 92 milli-international unit per ml. But after 10 cycle, the level was increased to 492 milli-international unit per ml. And 4 days after that, repeat beta ECG was done, and it was 58,000 milli-international unit per ml. At that time, her ultrasonogram images and report of this patient showing bulky uterus with 2 irregular hypoechoic masses in anterior myometrium of the uterus. Now, I have some questions. Start of chemotherapy without rescoring is rational.
You have to answer.
Sorry, sir.
I said you have to answer that. You have been treating the patient. Is it rational or
No.
not? What is your
No, sir.
opinion?
No, sir.
Yes.
Next.
So my question was on your thing. Why did you repeat this tumor marker at 3 days? What is the usual protocol you follow for post-evacuation of a mole?
Sir, this patient is treated up to this level outside NICRS, outside Dhaka.
Okay.
Now, my next question is, when should we do WHO scoring during the management of molar pregnancy? When should we do WHO scoring during the management of molar pregnancy, sir?
Question to me?
Yes, sir.
See, you have to do a scoring when you diagnose the patient with a gestational trophoblastic neoplasm. So for that, you have to be sure about the diagnostic criteria. So the first criteria, especially when you have any, when you're doing a tumor markers, you have to do it at weekly intervals. So there are certain criteria there. It should be a weekly rise for 3 weeks or plateau for so many days. So these are the criteria. So 4 values you do in one, that is for a plateau. 3 values, if it's rising, it's for a It indicates a trophoblastic neoplasm. And when you diagnose, or if you have a histology of a choriocarcinoma or evidence of any metastatic disease, so when you diagnose the neoplasm, at that time you have to do a scoring. So that is at the time of initiation of chemotherapy.
Okay, thank you, sir. When we switch to Imaco during methotrexate chemotherapy.
Raju Chako, sir. Are you here? Doris, I request Dr. Bhagdalakshi or Dr. Amitanan. Sir, please.
So then should I take it then again?
Yes, sir.
So essentially, when you started the chemotherapy, you have to monitor during chemotherapy. Also, so the monitoring continues with weekly serum HCG levels and symptoms. So when the serum HCG levels have to start falling by 1 log value after each chemotherapy. But the question is, you've written only methotrexate. I did not understand what methotrexate regimen you were giving for this patient. What was you have just mentioned methotrexate.
After methotrexate, we should do actinomycin D. But in this,
my question is which regimen of methotrexate? There are many regimens of methotrexate. So which one were you giving?
They have 1, 2, and 8 weekly, sir.
You are not giving rescue 1 milligram per kilogram and folinic acid or alternate days?
Sorry, sir. Methotrexate, folinic acid with folinic acid. Day,
same thing you're giving.
First,
no? Okay.
Day 1, 3, 5, 5th, and folinic acid second, 4th in this regimen.
Okay, fine. So when you're doing this prior to each course of subsequent chemotherapy, you're seeing the tumor marker. If serum HCG is not falling by 1 log, then if it's plateauing during therapy or rising during therapy, we have to switch over to the next therapy. That is usually Imaco or actinomycin D.
What are the causes of failure to Imaco therapy?
Dr. Bhagdalakshi or Amita? Dr. Raju Chapu is already left. He left. Probably has another meeting.
So, I mean, if you are talking about one general resistance to chemotherapy is histologic subtype, so epithelioid tumor or placental site trophoblastic tumors are not very chemosensitive. That's one group of patients of GTN who are chemo resistant. The other reason, I don't know what could be the very high score. So to start with, if WHO score is 13 or more, these are the patients who have higher chances of failure, especially patients with liver and brain metastasis. So these are cases who may not have successful outcome with Imaco.
Thank you, ma'am.
Amita, what about the persistent? I mean, if there is some persistent disease, I mean, can it be another cause of not getting it?
In the uterus?
Yep.
In the uterus?
Yes.
Yeah, I mean, that could be, although isolated persistent disease in uterus after Imaco is very, very rare. After single agent, we have like, a few cases. But yes, that also can be one of the cause.
Yes.
Then EP-IMA was started after 2 months of completion of Imaco and completed 6-cycle EP-IMA on 2nd October 2000.
Actually, what is missing in this case is imaging finding. So, where was the disease? Was it lung? What was the site of mets?
Uterus. It was the uterus.
Uterus only?
Yeah.
No,
Okay.
metastasis.
Yes.
There was no lung metastasis.
No lung metastasis, ma'am.
Yes.
Okay, then I think what is, we have to consider hysterectomy if she had persistent disease after IMA-EP also.
Thank you, madam. During chemotherapy, beta hCG level was decreased, but not to the level of baseline. After completion of EP-EMA, her beta hCG was raised and it was 110 milli international unit per ml. Then she was referred to NICRS for further management. At NICRS, on general examination, her performance status was good, mildly anemic, accessible lymph node were not palpable, and all other vitals were normal. On gynecological examination, all are satisfactory, except uterus was bulky, about 10-week size, and soft in feeling. This is the ultrasonogram images and a report of this patient showing uterus is bulky in size with a 5.8 centimeter into 4.6 centimeter mass in anterior myometrium of uterus, and the lesion invades the upper part of the endometrium and superiorly extend up to the uterine surface. This is the color Doppler image and report of this patient. Signals, loss of discreteness, and irregular vascular arrangement. Spectrum, this is the CT scan of whole abdomen of this patient showing heterogeneous myometrial density with strong enhancement after contrast injection. Moderate collection is seen within the uterine cavity. Here we can see the uterus with moderate collection. X-ray chest was normal. According to WHO prognostic scoring system, she was stage 1 and risk score 30, that is ultra high risk. And she desired to conserve her uterus for second baby. This patient was presented previously in this Tumour Board of Oncology Club in November 2020, and respected panel advised for 3-cycle chemotherapy with paclitaxel, carboplatin, and etoposide. 3-cycle chemotherapy with these 3 drugs was given from 20 November 2020 to 29th January 2021. And after 3rd cycle, her beta hCG level was declined, but after her completion of chemotherapy on 13th February 2021, her beta hCG level was again raised. It was 619 milli international unit per ml. Chest extra was still normal. On ultrasonogram, uterus bulky and 5.2 centimeter into 4.2 centimeter mass in anterior myometrium. Now, question is, why failure occur after initial good response? Amita ma'am.
I don't know the answer. There are some cells which are still remaining and which are causing. But again, I just want to know what was her maximum hCG ever reached? How much was the maximum when it was,
Beta is 110, ma'am.
Oh, 110. So, I mean, basically there is some disease which is, not responding to chemotherapy, that it's chemo resistant cells are growing or chemo is not reaching or whatever. So.
Thank you, ma'am.
And, even when beta hCG is normal, there are 1 lakh cells in the circulation, and that's why we give consolidation 2 or 3 cycles after beta normalization of beta hCG. So normal beta hCG in a case of germ cell tumor in GTN doesn't mean that there is no tumor cells are all gone from the body. Okay, so
Amita, what another comment I want to make, that it is not a good response. I will say there was a partial response because it was never touching a very normal baseline.
Right, absolutely. In this case, yes, it never became normal. And I think we have counseled this patient in, isolated uterus site of, if that's the site of chemo-resistant disease, she should undergo a hysterectomy.
Ma'am, we several times counsel the patient for hysterectomy, but she always desired to conserve her uterus for pregnancy, second pregnancy. My next question is role of EP-EMA as salvage therapy.
Yes, that's been used as the salvage therapy. EPEMA.
Thank you, ma'am. What is the role of immune checkpoint inhibitors in the management of gestational trophoblastic disease?
Yeah, so there are some reports suggesting role of immune checkpoint inhibitors in GTN, and you need to do, was IHC done for PDL1 here?
No,
Did
no,
you
not
check?
done.
No.
So we have given to maybe few patients, 2 or 3, and there is some, I think there is a response, but I really don't know long-term follow up the patients. But we can do immunohistochemistry and see if there is PDL1 expression positive. These patients may respond to checkpoint inhibitors.
Thank you, ma'am. At last, patient requested us for hysterectomy, and hysterectomy was done on 24th February 2021. This is the specimen, and histopathology report shows histologically consistent with choriocarcinoma. On 5th March 2021, her beta ECG level was less than 2.3 milli international unit per ml, that is within normal limit, and the patient is advised for follow-up after 2 weeks. Thank you. Thank you for patience hearing.
Thank you, Dr. Vixana. Nice presentation.
Yeah, thank you. Very interesting case. In fact, checkpoint inhibitors, especially in placental site trophoblastic tumors, there is some evidence these tumors are otherwise resistant to chemotherapy. So,
yeah, Amita, but what you mentioned, PDL1 positivity is the must.
Yes,
to go
yes,
for that.
yes.
So if somebody is thinking of that, there are some very impressing references came out, but as you mentioned, I mean, this type of disease, we don't know the long-term data, but there are some cases they have tried head to head and they found that it is doing very good when in PDL1 positive.
And I think it's US FDA approved for this
Yes, they
indication.
have approved it.
Very interesting case. So my only question is, this patient is any need for any, I mean, she has received so much chemotherapy. So I think we'll just keep her under observation, won't give any adjuvant chemotherapy after hysterectomy.
No, she's not in, she's now only in follow-up.
Okay, I think.
Thank you, Doctor. Please stop your screen shares. Now we'll go for the 4 questions again. Sholna, please.
Yes, ma'am.
Which of the following statement is false regarding the primary cytoreductive surgery? Systemic, pelvic, and parotid lymphadenectomy. It is done in case of resectable and advanced ovarian cancer, and total omentomectomy should be done. Gut resection or the peritonectomy may be needed. All are true except the systemic, pelvic, and parotid lymphadenectomy in early stage ovarian cancer. The following information should be obtained from CT scan of the ovarian tumor to take decisions of the primary surgery, except hepatic parenchymal metastasis, involvement of the root of the mesentery, involvement of the porta hepatis, growth on the surface of the ovary. The answer is the growth on the surface of the ovary, and 63% of correct answer. Next. This statement is true for the high-grade papillary serous carcinoma of the ovary. BRCA mutation is always present. Wild type if present, serous tubal intraepithelial carcinoma lesions may be present, and it always has the precursor lesion. 28% positive answer, that is serous tumor intraepithelial carcinoma. The 4 questions are ended. Now declare the winner. For her,
Yes, ma'am.
please.
Yes, ma'am.
Again, Hina Borua last week, she won, probably last week, she's from Rangamati, the senior consultant, Hina Borua. Farhana Hawk, our student and trained. She BS probably as far I know.
So congratulations, all winners and participants.
Hannah, we can finish and talk about the next week
Yes.
program. Give some idea for the next week program.
Yes. Yes. Sir, hi sir. Hi sir, क्या आसन ना मेरे sir. Hi sir.
Yes, I am here.
Sir, please. Sir, we want to arrange a full day workshop on the cervical cancers in next week and 6th April. And there will be a 3-hour session. Probably we may arrange it from 8 to 11 p.m. And there are the 2 sessions of the program. And the first session, there will be the evidence-based the practice. There the real-life scenario. And I requested Professor Dr. Amita Maheshwari ma'am to conduct the session, and she is agreed. And second part of the session is the Tumour Board. And I requested Professor Dr. Rupendra Shekhar to moderate the session, the Tumour Board, and she also agreed. And our plan is to invite all the medical college hospital who were with us in last days. And they are agreed with us. They will present their case, and our student, they will show the evidences, and our expert faculties will comment. And we will also invite all the faculties who were with us in last days. Sir.
When is the date? Did you fix the date?
Yes, sir. Next Tuesday, because the
Tuesday, sir.
13th Tuesday, probably there is the fast Ramadan. So during the short notice, we have to arrange this, sir.
When you want to start it? Time?
Always it is 8 p.m.
Sir, they are thinking to do it from 8 to 11.
8 to 11, yes.
4 hours time.
3 hours, sir.
3 hours, sir.
3 hours. Okay.
So Shahana, my suggestion will be please share the type of topics that you have decided with Amita. She may have some idea to modify it for the first real life challenge issues, so that we can really give some good message under the umbrella of evidence to how to face these challenges before finalizing it.
Yes.
So we can finish it now, Shahana. It is 10:50.
Yes.